Okay. Hello, everybody, and welcome. We might get started. There's quite a few of us here already, and no doubt people will trickle in over the next few minutes. But we've got a lot to get through, so I might get underway. I want to start off just by welcoming all of you who are here, and to those of you who will be catching up online later on. This meeting is being recorded, so welcome to those of you too who are watching this on delay. For those of you who I haven't met before, my name's Kate Sear. I'm a professor in the Deakin Law School at Deakin University and the co-director of the Centre for Law as Protection. I'm also one of the founders of the Australian Alliance for Inclusive Healthcare Standards, which we're really proud to be formally launching here today. And I'll tell you all a bit about the Alliance in a moment. But before we get going any further, I'd just like to acknowledge that today we are meeting on the lands of many First Nations peoples. I'm based in Melbourne or Naarm. I live and work on the lands of the Wurundjeri people of the Kulin Nations. So I'd like to pay my respects to elders past and present. I'd also like to acknowledge any Aboriginal or Torres Strait Islander people who are joining us in the meeting today and to acknowledge the traditional custodians of the many lands on which we are all located today. And feel free to pop in the chat where you're joining us from today. It's always really nice to know where people are coming in from and to have that sense of connection with you all. And I'd also, of course, like to acknowledge that Aboriginal and Torres Strait Islander people remain strong in their enduring connections to land, water, culture, and sky, and to acknowledge the significant impacts of coloniality, of racism, discrimination, bias, and stigma on First Nations populations, which are all stigma, of course, is the focus of today's seminar. I'd also like to acknowledge the considerable contributions of people with living and lived experience to the work that we're going to talk about today, and to acknowledge people with living experience who are joining us here in the meeting today. So, as I mentioned today, we're really delighted to be launching this new alliance, which is the Australian Alliance for Inclusive Healthcare Standards, or AAFIHCS for short. And before we get into the details of the Alliance, what it's about, who we are, what we're doing, why we're acting, and what we're hoping to mobilise you all in today, I want to introduce to you Andrew Wilson. Andrew is from the Weight Issues Network, and Andrew is going to say a few words to us about why stigma in healthcare is an important or significant problem and why action on it matters, just in order to set the scene for the discussion that we're about to have. So fingers crossed our video works. And Sean, if you could press play for us, that'd be great. Oh, I'm not getting sound. Are you getting sound? I'm looking at Carla or Sean.
No.
Might just try that. Try that again, Sean, if we can.
Sorry, I don't think that's working for me, unfortunately, Kate. Perhaps we can share it later in the meeting.
We will. Thank you, Sean. And yeah, apologies for tech issues. But thank you very much to Andrew. And as I said, as Sean mentioned, we will share that with you all after this meeting today. So let me tell you a little bit about today's webinar and what we're wanting to do. The structure of today's webinar is quite straightforward. We're going to introduce who we are and say a little bit about the Alliance and why it is that we are activating now. We're going to provide a brief outline of why stigma matters in healthcare. No doubt an issue that will be familiar to many of you. but just again to provide a bit of a broader context for the work that we're undertaking. And then we're going to say a little bit about standards, healthcare standards in Australia, in particular, the national safety and quality standards. We'll say a bit about what they are, how they operate, why they matter, and how it is that we think those standards might connect to stigma or anti-stigma, stigma reduction work. We're then going to hand over to all of you. We're going to have a bit of a Q&A, time for discussion. We're going to ask what you are looking for, what we can do, how we can help you to work together in this work, where we are essentially trying to forge work, anti-stigma, stigma reduction work at the structural level, at the level of Australian healthcare standards. And so we'd like to hear from you in that later part of the webinar about how we can support you in that work. And finally, we're going to invite you to connect and to keep talking and to try and bring us all together throughout the course of 2026 to work on anti-stigma or stigma reduction initiatives. So if we can go to the next slide, thanks, Sean or Carla. Let me just tell you, first of all, about who we are and how this alliance came about. So this is an alliance that's been founded by 4 of us who are all here today. You can see us with these blue slides, so easy to identify. The founders of the alliance are Elizabeth Devaney, who is CEO of the Consumers Health Forum of Australia, Sean Mulcahy, who's based at the Australian Research Centre in Sex, Health and Society at La Trobe University, myself, and Carla Treloar, who's based at the Centre for Social Research in Health at the University of New South Wales in Sydney. Together, the 4 of us have been researching, writing about, and advocating for stigma-free healthcare for some years and for improved quality and safety for consumers, healthcare consumers in Australia. And this work has been going on in many different ways over the last few years. But in recent times, we've come together because we've identified an important opportunity that we think exists for all of us who are here today to become more activated on stigma reduction and to do so in a way that's a bit different to how we might have advocated for stigma reduction previously. So this brings us to say a little bit about the national safety and quality standards, which I mentioned earlier. So the next slide. Thanks, Sean. So as many of you might know, the national safety and quality standards govern health systems in Australia. Various services must be accredited against these standards in order to receive funding. And in 2026, these standards are actually under review. They're open for public consultation. The fact that they're under review gives us what we think is a rare opportunity to shape what safe and high quality healthcare in Australia might look like over the next decade. And in particular, what we in the Alliance have identified is that stigma does not currently feature in these standards at all. And that's despite the fact that stigma is a very important concern for many, perhaps most, healthcare consumers in Australia. But as I said, the concept of stigma and activities to work on or reduce stigma are not mentioned in these healthcare standards at all. And so the Alliance is designed to bring us together to advocate around this particular issue. It's about taking action on stigma at the structural level, and in particular, advocating to try and get these standards to recognise and address stigma and for healthcare systems to be governed by and accredited against stigma reduction initiatives. If we can go to the next slide. Thanks, Sean. So we see ourselves essentially as a central clearinghouse. This is a time-limited initiative brought together to mobilise around the review of the healthcare standards. We see ourselves as here to do a few things. First of all, to bring us all together as we're doing today, to help inform all of you about the existence of the standards, the existence of this review, the opportunity to get involved, to provide you all with updates about how you might get involved, and to provide you with resources if you and your organisations are interested in being part of this initiative or in advocating along the lines that we're describing. And I'm going to say more about exactly how it is that you might get involved at the end of this webinar. A couple of things I will say is that if you've got questions or comments along the way, please feel free to pop them in the chat. And when we get to the discussion section, we'll attempt to address them if anything's unclear or to hear from your suggestions. And if you're wanting to submit a question to us anonymously, please feel free to email Carla Trelaw, and Carla will then read out those questions anonymously later on. So the Alliance has developed a set of principles which really articulate what we think key concerns and priorities should be when thinking about stigma as a safety and quality issue in healthcare. I'm going to briefly run you through those principles, and then I'm going to hand over to my co-presenters who are going to provide you with some more background on the initiative. So in terms of the principles of the Alliance, you can see, first of all, there that we argue that stigma in healthcare is not solely an interpersonal issue, but a systemic risk factor that can lead to measurable harm. Stigma occurs when individuals or groups are excluded or judged or treated differently because of inherent characteristics or health conditions. It can be embedded in laws, policies, clinical practices, organisational culture, language and service design, and of course all of these things interact. Stigma contributes to various problems, including delayed care, avoidance of services, non-disclosure of relevant information, reduced adherence to treatment, and poorer health outcomes. Where stigma affects clinical interactions, it compromises informed consent, shared decision-making, and patient safety. Healthcare that involves stigma cannot be considered to be high-quality care. Safety and quality are diminished when patients do not feel safe to speak openly and seek care early, or to participate fully in the decisions that affect them. The impacts of stigma are not incidental, but rather they are predictable, preventable, and measurable. We can go to the next slide. Thanks, Sean. Thank you. Evidence demonstrates that stigma disproportionately affects participants from certain backgrounds, including people living with chronic illness, disability, mental illness, those from culturally and linguistically diverse communities, LGBTQIA+ communities, Aboriginal and Torres Strait Islander peoples, and others experiencing structural disadvantage. And this, again, results in reduced access and outcomes. So crucially, what we say in the Alliance is that reducing stigma, and we know this from research that's been undertaken over many years, really requires action at multiple levels. And that includes organisational, policy and regulatory levels, some of which we argue have been historically relatively neglected, and this Alliance aims to act at those levels. So we say that stigma reduction should be embedded within safety and quality systems, not as a separate or optional initiative. In particular, Australia's national safety and quality health service standards should explicitly recognise stigma as a safety and quality risk and incorporate actions to prevent and address it. Safety and quality frameworks should include mechanisms to monitor, measure, and continuously improve performance in reducing stigma-related harms. And finally, people with lived experience in stigma must be partners in the design, implementation, and evaluation of these strategies within healthcare services. So I'm now going to hand over to my colleague, Carla Trelaw, who's going to help set the scene for this work by saying a bit more about stigma and recent stigma work and how the Alliance has developed. So Carla.
Thanks, Kate, and hello, everybody. Lovely to see such a terrific bunch of colleagues on the chat, on this call today, and those who are watching later. Sean, next slide, please. So without, labouring the point, we just wanted to give a little bit of information about how we're coming at this notion of stigma and why the standards are so important, linking it back.
Carla's frozen for a second for me. We'll just give Carla a moment to rejoin us. Might be just taking a moment with tech. Okay, she's just told us that her computer has done a bit of a restart on her and she's just trying to get back in. But I might just pick up and jump in while Carla's rejoining us just to say a little bit about stigma by way of background. So as Carla was saying, and as we know, the definition of stigma, or as many of you will know, the definition of stigma comes, the defining characterization comes from the work of Irving Goffman back in the 1960s, who argued that a person experiences stigma when they're treated differently or expect to be treated differently because of some attribute that marks them as inferior, allegedly inferior. If we can go to the next slide, thanks, Sean. So research tells us that there are 5 components needed to produce stigma. First, distinguishing and labeling people on the basis of difference or alleged difference. Second, associating human differences with negative attributes of various kinds. Third, separating us from them, so-called. And fourth, status loss and discrimination. Fifth and finally, it's about dependence on power. And that's really crucial, that there is a power differential that enables certain groups, certain individuals, people with certain attributes to be stigmatized, or to be thought of as different and to be treated as less than. Now, work tells us that stigma operates at a number of different levels. The individual, interpersonal, organisational and structural. And I flagged this briefly at the outset, that stigma is enabled by differential treatment, labelling practices, resourcing differences, a whole range of processes at each of these levels. And often stigma reduction initiatives or anti-stigma work has been undertaken at the individual or interpersonal level. For instance, the provision of psychological support, training and education to staff and the like. But the organisational and structural levels have tended to have less work done. And here we're talking about the way that laws, policies, processes, regulatory mechanisms and the like can enable stigma. I think Carla might have rejoined us. Are you there, Carla?
I am. What a painful technological process. So apologies, I'm just on my phone. Rejoins the world.
Our sound, Carla, your sound is a little tricky for us, so I don't know if you have headphones that you can pop in.
Can you keep going, Kate?
I will. Yeah, no problem at all. And Carla, just let us know, type in the chat or anything if you're able, if there's anything you'd like to add. So as I was saying, stigma operates at these various levels and is enabled by law, policy, regulation, process and practice. And so what we are doing is really trying to target work at those higher levels in order to try and tackle stigma. In terms of stigma power, I mentioned earlier the importance of power and the fact that stigma is dependent on power for its operation and for its longevity, persistence. Cultural and ambient stereotypes harm stigmatized groups, even in the absence of direct person-to-person discrimination. It's often buried in taken for granted aspects of culture, thereby hidden or misrecognized by those causing harm and by those who are being harmed. It involves keeping people down, keeping people in, and keeping people away. And so in order to eliminate or reduce stigma in healthcare settings, work is required at all of these levels. If we go to the next slide, thanks, Sean. So there are a range of reasons why we should be concerned about stigma, and no doubt for everybody here today, you'll be familiar with this, with these reasons. In addition to keeping people down, in and away, stigma costs people dignity. It limits their ability to claim rights, including their right to safe, equitable, quality healthcare. Stigma increases distress, heightens isolation, lowers people's quality of life. It impacts their access to healthcare accordingly. It can reduce their trust in healthcare, impact disclosure, we mentioned earlier, can also affect their willingness to seek care, treatment adherence and the like. And it produces a range of predictable, avoidable, preventable, individual and societal costs. If we go to the next slide, thanks, Sean. So in terms of our own work as a collective, we've been working on stigma in the last few years. An important paper that came out of the United States back in 2018 argues that there are many different conditions, identities, and practices that are stigmatized. That paper from the United States suggested that there are at least 93 different conditions, identities, and practices that might attract stigma. And in a much larger project that Carla has been leading over the last few years with many partners, many of whom I can see on this call, our list of conditions, identities, and practices is much larger. It's currently sitting at in excess of 170. We argue that health systems can't possibly attend to each individually, and that we need to instead think of ways to address stigma and to reduce and ideally eliminate stigma for everyone systematically. In work that Carla's been leading on stigma-free healthcare, we found as part of that project that when we asked healthcare workers what might bring about a positive change in healthcare systems to address stigma, many possibilities were thrown up, but one of them was accreditation. We heard from people that we interviewed that some rigorous, formal and legal processes were needed at the structural level, that we needed to tackle stigma at that level, and that it would have then a cascading effect through tertiary education, underpinning organisational codes of conduct, performance reviews, etc. But really it was about addressing stigma at that higher organisational level. If we can go to the next slide. Thanks, Sean. So this brings us to the National Health Services, the National Standards on Safety and Quality Healthcare. As I mentioned at the outset of this webinar, those standards govern healthcare practice in Australia, but they don't include any references to stigma. Instead, the healthcare quality standards focus on the stigma of individuals with a particular condition, but only 5 out of 19 condition-specific clinical care standards include any references to stigma. When standards do talk about ways that care can address stigma, they predominantly focus on changes to language. So they're really operating at the interpersonal and individual levels, and they have limited consideration of structural stigma. They don't explicate what cultural change might be needed in order to try and counter stigma. All of the standards do reference cultural safety, but the impacts of gender on stigma are not explored in the standards. And I should also add, from memory, and Sean and Carla can tell me if I've got this wrong, but also I think race is an issue that is somewhat overlooked in that respect. Okay, to the next slide. Thanks, Sean. So we argue that it's important that a principles-based anti-stigma approach be adopted in these overarching national standards using a universal framing. That is, rather than dealing with individual conditions one by one, talking about stigma-free care for all Australians, regardless of the attributes, conditions that we might be talking about. Standards, we argue, should adopt and promote a rights-based approach to the provision of healthcare that also identifies stigma reduction as a human rights issue and addresses the legal environments within which they operate. And in part, that idea comes out of work that Sean and Carla and I have been doing in recent years, which looks at some important legal and human rights related developments that connect to stigma. References to partnering with consumers need also to be strengthened. Again, the idea here is to require health organisations to consider cross-system collaborative groups to bring staff together and consumer representatives to work at the organisational and structural level. And importantly, in order for those standards to be effective, they need to include indicators where stigma can be monitored over time, and the effectiveness of strategies to reduce stigma within healthcare systems can be reported on. So this is really about doing all of those things through the standards. I'm now going to hand over to Sean Mulcahy, who's going to say a little bit more about the standards for those of you who are not yet familiar with them and how they work. Sean.
Thanks so much, Kate. So as Kate mentioned, I'm Sean Mulcahy. I'm a socio-legal researcher based at the Australian Research Centre in Sex, Health and Society. My research investigates human rights law and its application to marginalised populations, including people who use drugs, people with blood-borne viruses like hepatitis or HIV, as well as LGBTIQA+ populations. And I think what's consistent in all of that work is that law and policy can often be an enabling environment for both, unfortunately, creating, but also developing strategies and being utilised as a bit of a stick to combat stigma, in this case, particularly within healthcare settings. So a key aim for our new Australian Alliance for Inclusive Healthcare Standards is to communicate to the Australian Commission on Safety and Quality in Healthcare, which is the key regulator in this space and which sets in place the standards, just how important elimination of stigma is for high quality and safe healthcare systems and services. So what that requires is a recognition that stigma is a quality issue and that does impact the safety of people who are accessing our healthcare systems and services. For many of us, we're concerned about issues of inequity, of discrimination, of bias in the provision of healthcare services and in the systems that underpin them. So addressing stigma is an important way of tackling those issues of discrimination, bias and inequity in the provision of healthcare. But it's important that the Australian Commission on Safety and Quality in Healthcare recognises the importance of elimination of stigma and provides for this within the new national standards. So what are these standards? So the National Safety and Quality Health Services Standards are accreditation standards, essentially. Well, they're standards by which public and private hospitals, day procedure services and public dental health practices are required to be accredited to due to funding arrangements with state and territory governments. That said, it's not just these particular healthcare services. Many other healthcare facilities choose to be accredited. So they're very important in setting in place enforceable standards in the sense that they're connected to accreditation and through that to the funding for healthcare services. So they're really influential and we believe a key opportunity to influence actions from healthcare service providers to address stigma. So another key aim for us is in both getting the Commission to recognise the importance of the elimination of stigma, but also to provide them with possibilities for the inclusion of stigma reduction within the National Safety and Quality Health Services Standards. So it's one thing to get the Commission to recognise the importance of stigma reduction and stigma elimination. It's another thing to impress on them the strategies and tactics that they can take to reduce stigma within healthcare settings. And that's what we're trying to develop in our various submissions to the Commission on the new standards. And that's where you also play an important role as various different organisations who we hope will play a role in making submissions to the Commission in its development of new standards, insisting on stigma reduction and elimination within those new standards. So we're also keen to learn from you what you think would be useful to support your own advocacy within this space and your engagement with the Commission in its review of the national standards. Carla, I believe, is going to share a poll now. Thumbs up. So That is looking good. It is a multiple choice poll, and we'd love to hear from you what you think would be most useful to support your own advocacy. So to go through these, you can see that now popped up on your screen, and feel free to click as many options as you think might be useful for you and your organisations. So to go through them, these can include things like a petition to the Commission on the need to address stigma elimination and reduction within the new national standards. These can also include things like an open letter to the Federal Minister of Health, who oversees the Commission, again impressing upon them the need to include stigma elimination and reduction within these standards. Would also be very happy to share any information that would be useful for your organisations in making representations to the Commission. This could include template submissions that your organisations could adopt if you think that would be useful within your advocacy. We also know from other organisations that online submission writing sessions can be very helpful. We've seen this done by other groups within various different sectors, points where we can come together and actually find in our busy lives sometimes to actually sit down and draft submissions to the Commission on this. And we're also happy to draft up letters of support that your organisations could provide. We know, like, for many community organisations in particular, doing policy submissions can be quite onerous, especially they've very few staff and often very volunteer-led. So we're happy to come up with letters of support that your organisations could utilise in your advocacy as well too, and take some of the burden off your organisations in terms of drafting submissions and the like. So I think we might have some results coming through from the poll now. Carla, do we have any insights so far?
Yeah, information sharing's getting the highest endorsement at the moment, but lots of interest in other options as well. And I've just put in the chat, are there other things that would be useful? Let us know. But I might end the poll now.
Wonderful. Thank you so much, Carla. And of course, that doesn't cut off your opportunity to engage with us just through that poll. We'll have more information when we get towards the end of the session about how you can engage with the Alliance going forward and how we can support your advocacy work when it comes to the review of the new national standards. And I might hand over to Elizabeth now, who'll take us through a bit of a discussion and a Q&A where you can share with us what else you need to know from us that you think would be helpful in terms of your organisation's engagement with this review and development of new national standards, the role that Stigma could play in terms of your recommendations towards the Commission, and any other questions or issues that you might have. I'll pass over to Elizabeth now.
Thanks so much, Sean. Hi, everyone. There are a couple of things in the chat that we could probably use as the beginnings of questions, but if you have questions, Carla put her email address earlier on, and I'll ask her in a moment whether anyone's emailed her directly a question, but you can also pop them in the chat and we can ask them that way. Carla, has anyone sent you an email?
No.
Okay. No emails at all. I mean, that's pretty good in half an hour.
I didn't say that, but no emails from this meeting yet.
Okay. Jolly good. Well, there are a couple of things that come out of the chat that I might start with, and I'm just going to throw this. I don't know whether we can, at the moment, I'm only seeing you, Carla. I don't know if we can, that might just be how I've got it set up though. One of the questions that came a bit out of the comment that EJ made, which is there's an intersection between diversity, or what people might call diversity, and stigma. So when you look at the research evidence that you talked about, a lot of that could also be described as, these groups might be described as diverse. So how do we see that intersection between diversity, and there are various other words that are used to describe different groups, people experiencing disadvantage, and the work we're doing in stigma? Does anyone want to make a comment on what EJ said in the panel?
Carla, I wonder if you want to take that and say a little bit about the the work that you've been leading and offer some reflections.
Yeah, there's obviously connections between some of these concepts, diversity, inclusion, cultural safety, even discrimination protections, and then stigma. So part of what I think I'd be challenging or wanting the Commission to do is have some clarity around these different concepts of what are the intersections, what are the actions required, and in particular, with our focus on stigma, what else we need to do. Because one of those earlier slides was stigma has the ability to harm people even in the lack of direct interaction between people. So that's a real challenge for health systems to think, well, what is it that we can do here? And this is where I think we can push as an alliance to say you have to do something, but also give the Commission and AHPRA and other regulators some tools to help them distinguish between these various concepts and constructs, and then real life activities to address some of these.
Yeah, that's great. And also Sharon mentions the concept she describes as self-stigma. Do we see that as part of this also, that kind of, it's a bit Foucauldian, isn't it? Self-surveillance, self-stigma.
Yeah, that's a real, in that picture that I couldn't present because my computer lost it, with those stacked levels, and the individual is the first one where the people take on these messages that are swirling about people like them, and that's internalized stigma or self-stigma, and that can be the part of the reason why it's really hard to turn up at a health service or really hard to disclose at a health service, because you carry the weight of those stereotypes with you. So ensuring that health workers and health systems are aware that this is part of the picture, and these things might have happened even before the service started. And those impacts on people have been, for some people, there for a very long time, but it's part of the competencies that we would like from health services and health workers to understand. This is part of stigma, is that people might feel very difficult to turn up, might feel very difficult to disclose, might feel difficult then to carry on with prescriptions from health systems because of that weight of internalized stigma.
Yeah, great. And there are a few comments with people suggesting other ways they might like to get engaged. And they're more face-to-face. So people are saying, what about coming to our service and talking about this, like grand rounds kind of thing? Someone else is saying, what about us hosting some kind of round table where we could have ministerial or other key kind of decision makers there to listen to people's lived experience? And someone else saying, what about a whole lot of us front up for a meeting with the Commission and eyeball the relevant people? So that kind of sense that perhaps some of this should be face-to-face as well, and that might be more influencing or provide an additional kind of mechanism. So I just mentioned that to the rest of the Alliance members for us to think about whether we could do something like that. And I don't know whether Sean, Kate or Carla have a view about that.
I mean, my view is that they're all fantastic ideas, Elizabeth, and ones that we will probably have to go away as a group and have a think about how best to coordinate that. I know that when we first got together and talked about launching this alliance and sort of trying to mobilize and activate people here in this work, we did talk about whether a direct approach to the Commission was strategically advantageous, or whether there might be other ways. And perhaps, I'm very keen to hear what people think about that, if they have had their own experiences with the Commission or other ideas. Yeah. Sorry, and I think Carla unmuted just as I was too, was going to comment.
Did you want to add anything, Carla?
Yeah, and just to say, that the four of us don't own any of this. We're just here as an organising point. So really want to provide anybody here on the call or listening later with the tools they need to make representations in their spaces. So if there's things that we can provide that help you, just give us a shout. But I think we're also very activated to be directly involved if that's helpful in different circles as well.
Yeah, we're a bit of a kind of autonomous, almost anarchic collective here to support the greater good, and happy to help where we can, and also to lean on others too if you've got more resources than we do. Ali's asked a question, and Ali, there is a recording of this, and at the very beginning we did a bit of definition work that talked about, you know, different versions of stigma, and particularly we're focused on that kind of structural organisational stuff. And you're right, that can still have an intersectional impact. But if you've got the time one day to go back to the first 10 minutes when the recording comes out, you'll see a bit of definition work there. But certainly we would recognise that you may believe you've been discriminated against or feel that you've experienced stigma because of a range of reasons, not only one, which of course then can be particularly disadvantaging to some people.
Can I just jump in, Elizabeth, at that point too, and just say something in relation to Ali's question? And I'm going to invite Sean in at this point to perhaps say something about this. Sean and Carla and I have just finished writing a paper, which is currently under review with a journal, and so not yet out, but we have our fingers crossed that it will be soon. That looks at other international healthcare standards with a view to exploring whether stigma is something that is dealt with in other healthcare standards around the world. And I wonder, Sean, whether you want to say a little bit about that analysis and what we've found, because that once that paper's out, that's the kind of thing that we will be able to share with everybody on this call to help provide some broader context and perhaps some resourcing that you can use to advocate in this work. Sean.
Thanks, Kate. So our analysis has shown that there's actually no mention of stigma at all in the Australian national standards. There are in some of the condition-specific standards, but they tend to focus on cultural safety. There isn't really any discussion of gender, and certainly not any discussion of intersectional experiences of stigma. The cultural safety recognition goes some way to recognizing issues around stigma for racially and culturally minoritized groups, but I also take on board EJ's very good point that there is actually no definition of cultural safety within the standards. There's scant mention of diversity within them, and there's a need to see cultural safety and respect better defined within the standards as well too. So I think there's a lot of opportunity for us to ensure that we bring an intersectional lens towards the development of particular provisions within the standards around addressing stigma. And I think there's a real opportunity, considering our work has looked internationally at standards in other jurisdictions such as the US, the UK, Canada, and Ireland, to actually be an international leader in terms of addressing issues related to stigma, particularly from an intersectional lens as well too. And I also note Jackie was asking a bit about gender bias in healthcare, and yeah, unfortunately, that's an area where which really isn't properly addressed within the standards at the moment. Again, there's some mention of specific issues impacting women in some of the particular standards, mostly related to reproductive or sexual health care, but there isn't a strong gender lens across any of the standards, so there's still a bit of work to be done within this space. Kate, was there anything further that you wanted to add on that?
No, that's great, Sean. Thank you.
There also seems that I'm just going to throw this again to the group in the chat, which is fantastic. Keep all your ideas and thoughts flowing through. It's really great. Is this notion of language being important? So are we talking about discrimination? Are we talking about stigma? Who are we talking about? We're talking about bigotry, bias, disadvantage. And I think we all know this is complex, that different people will identify their experience and describe it in different language. So we've used the word stigma because it's a word that we have used in research and so on, but we also recognise that people will use different language. This is not meant to be exclusive of those other experiences and or words that people might use to describe what's happened to them or how they've felt. I don't know if we did a bit of definition work at the start, but I don't know if Sean or Kate or Carly want to talk a little more about that.
Just to note that, yes, it's an area where there's a variety of different words that can be used. Some use the language of bias, some use the language of inequity, others use the language of discrimination. These are all terms that have slightly different meanings, but they are, generally speaking, coming from the same place. We use the term stigma ourselves for various different reasons, which I'm sure Carla can touch on further. But I think anything that is that uses the language that you or your organisations are familiar with utilising that still addresses these issues connected towards stigmatised, discriminatory, biased, or inequitable treatment in health services is important.
Yeah, it's an interesting thing, and I can see some things in the chat. Like for me, one of the issues is, just to talk about discrimination versus stigma for the moment. There's some really important protections in law for some things for within or anti-discrimination law, and that's awesome. But not everything is protected within anti-discrimination law. And there's stuff that happens that will never reach the threshold for legal definitions of discrimination, nor does discrimination really account for what has been coming up in the chat in some ways, that the self-stigma. That exists for someone, including myself, right today. But it may be experiences with people, with systems, with policies that have happened over many years that have constructed the way I feel about myself today and my decisions about whether or not I'll go and seek care for something. So that's not that for me, that's a really important distinction between discrimination and bias that might be seen as things that people do compared with the impact on people, which pre-exists even the system that they're deciding whether or not to engage in, as do those cultural stereotypes that float around and inform how we think about ourselves and other people. But they absolutely shape what a system is, how it thinks about itself, and how it thinks about its clients. So for me, there are very important distinctions between these different elements. And I think it's a good challenge from the people in the chat for us to get a very clear distinction of why we are so focused on stigma and why it matters, even above, as well as, and not discounting the other elements of bias and discrimination and cultural safety, etc. I think we need to make that case very clear, and I think good message today that clarity is still not quite there yet.
Yeah, great, thanks. And you've probably partly answered Fiona's question, but I don't know, Kate, from the kind of legal perspective, because Fiona also asked, what are our views on the potential tipping point for anti-stigma standards into anti-discrimination legislation? And Carla, you've answered that in part in terms of stigma and discrimination are kind of part of a Venn diagram. There's definitely an area where they overlap, but it's not quite that simple, maybe. I don't know, Kate, from the perspective of a Legio, do you have any other thoughts?
Yeah, it's a good question, and I might just deal with a couple of questions in combination. I can see Dion Kagan's written some comments there too, or comments and then questions about these distinctions and points of overlap. And Dion's asked whether there is a potential scope for him and his team, Health Plus Law at University of New South Wales, to make a submission on these issues. And the answer is absolutely. And as Carla said earlier, this is not a space that we own. We are really just wanting to come together to activate all of you in whatever ways work for you and your organisations around these issues, and to try and sort of bring a spotlight on the fact that stigma doesn't feature in the healthcare standards, and we think it should. So, Dion, the work that you're doing and your team's doing is very relevant, and if you have capacity, yes, please do make a submission. But back to Fiona's question, I think Carly did a wonderful job of explaining that there are distinctions between these concepts in law. And I would also say, as Dion mentioned, that sometimes these are collapsed into one another. And I think often when people talk about stigma or the kinds of experiences that people describe as stigma, I think often what they're talking about is discrimination in a legal sense, unlawful discrimination that is actionable and that where people have rights that they can pursue when they have been treated in that way. But increasingly, and Carla and Sean and I have written about this recently in a paper that's been published in the International Journal of Drug Policy. We have looked at a particular court case that's been decided in Victoria in the last couple of years that we think is very important because it's essentially, we think, describes a particular form of stigma that was experienced by an individual who died in custody as drug-related stigma and as a legal problem. And so that I think is an interesting case because what it does is really position stigma as both wrong in fact, wrong in practice, but also a kind of legal wrong, which is distinct from discrimination, but no less important. And so I would encourage you to have a look at that paper and have a look at that work and reach out to any of us if you've got questions about it, because I think it shows that stigma is increasingly thought of and spoken about as a legal and human rights problem, and it's getting this kind of elevated status and different kind of attention, which I think matters.
Fantastic. Now, I'm conscious we've just got a few more minutes, and I want to throw back to you, Kate, because you want to talk to people about how they can get involved. And while we do that, I'm going to pop a few links in the chat that are useful for people too. Thanks, Kate.
Thanks, Elizabeth. And as I said, please do feel free to reach out to Elizabeth, Sean, Carla, and myself if you've got any questions. But in terms of how you can get involved, I wonder, Sean, if you might be in a position to share the slides again, just if you've got access to those, and I'll start running through what we want you to do. So really what we wanted to do today is to bring you all together to get involved in this call to action. The main purpose of today's initial webinar is just to communicate with all of you about this work. For those of you who aren't aware, to bring attention to the standards and this opportunity that exists within 2026 to advocate around them if you have capacity. In terms of getting involved, what we'd like you to do, it's lots of opportunities, but we'd like you to communicate with others, to share on your socials information about this work and this initiative, to talk about the standards, to talk about how your colleagues and other cognate organisations that you work with or collaborate with might get involved. You can follow the Alliance on LinkedIn, and I think Elizabeth has just shared the details in the chat there. So we're on LinkedIn. If you follow us on LinkedIn, you'll then be able to get access to any of the announcements that we make along the way. We will do things like provide you with updates in relation to the standards consultation process when those are made available. We also have an email list, so we'd like to invite you to sign up for our email group so that then again, when information comes out about the consultation process, you'll be alerted to it that way. You can participate in the consultation, whether as an individual health consumer, a carer or an ally, or perhaps a researcher or somebody who wears more than one hat at the same time. You might also want to prepare your organisation. So if you are on the board of an organisation or have access to the board, a CEO that you can talk to, please go and talk to them about this work. Let them know that the standards are being reviewed this year. Let them know that they don't mention stigma, that this is something that you and your organisation might want to advocate for. We will undoubtedly have more of these webinars as the year progresses. And when we do, we will announce details of those both on LinkedIn and through our email list. So if you've signed up to either or both of those, you'll get information, and we would like you to come along and we can continue this conversation, including we'd invite you to contribute any strategies that you have for advocacy. And I know that there were some great ones mentioned in the chat earlier. We'd like to also encourage you to spend time getting familiar with the standards. Many of you will be familiar, of course, but some of you might not be. And so Elizabeth has shared them there in the group, in the chat, and you can have a look through the standards in your own time, see what language they use, have a think about if, for instance, you plan to make a submission on behalf of your organisation, where within the standards you think stigma might be mentioned, what is the best place, what's the best language, how you think that should be done. And share strategies and share information that we share with you through your networks to try and get as many people activated in this campaign as possible. You are very welcome to share or use any of the materials that we share with you here on LinkedIn or on email in your own submissions to the National Quality Standards consultation when that opens. I can see that James has asked when the draft standards will be released, and as Carla said, we're not sure yet. If you have colleagues or other organisations that you collaborate with who might be minded to make a submission and need support or help, we'd encourage you to offer them that help. Again, share resources with them. We will share our publications with you when they're out, and you're welcome to pass that on to anybody else. And as I said, otherwise participate in the conversation as much as possible. Looking at Carla, Sean and Elizabeth and wondering if there's anything I've missed.
Andrew is on the line with us also, because we couldn't show your video earlier today, and happy to say something. I don't know whether we need to give him permission to do that from the hosts, or whether he'll be able to just simply unmute.
Andrew, I think you should be able to unmute.
Yep,
and
I've unmuted. Thank you.
Great. Over to you, Andrew.
Okay, so just very excited that we're moving to this phase, and this is so important that it's so needed in our community. Just very excited that it's being rolled out, and to be part of this journey for a little while now. And yeah, I'm delighted with the interview that I had recently about this subject, and if it's okay, I'm going to share it with other people because yeah, I just had a conversation earlier today just about stigma in hospital at the moment. Just had a recent conversation in a meeting I was just at, and yeah, things are slowly changing, but this is going to make it change a lot quicker. This is going to accelerate things and bring it all, make it inclusive for everybody, and I love that approach. And I don't know, what did you want me to comment about? There's just so much I could talk about with this. I'm just a massive fan of what's happening right now.
I think that's great, Andrew. You know, we're so sorry the video didn't work the earlier in the meeting, but this is what it's all about, is centering the voice of lived experience and making sure that we are inclusive for everybody, because there's so many people who are affected by stigma, and just want to, rise all boats, as they say, by centering that lived experience right in the middle of it all.
Just people just came off a phone call, just literally very, very recent, just an hour or so ago, and a person in hospital in Sydney, a lot of intersectionality, treated very well at the hospital for majority, and right at the end, it just got the stigma right at the end, and very unfortunate. Most of it was great, but right at the end, and just shows the need for some uniform approach to this subject, and it's very real. It's part of us. It's part of the community I'm in. A lot of people are suffering from this. So just very buoyed by what's happening here. So just thank you very much for working in this space, all of you. Really appreciate what you're doing. Thank you very much.
And just in finishing, I have had the really easy part. So I'd love us to give some reactions and love to Andrew using the reactions. Some people have started doing that. If you can find it, at the bottom you should have a react, and it gives you some options. But also just to thank all of my colleagues who, as you can tell, are doing the heavy lifting. I'm just here for my good looks, who have done not only a mountain of research, but also a mountain of work in getting this off the ground. So I think a big thanks to the fangirling now, the three of you, Sean, Carla and Kate, for the amazing work you're doing in this space. And we look forward to getting a positive response from the Commission to what will no doubt be some amazing advocacy on our behalf. So I'm going to throw back to Carla or Kate to close the meeting.
Kate,
Thanks, Elizabeth. Yeah, thanks, Elizabeth. You're not just here for your good looks, but we're here for our good looks too. I'd like to, if I may say so. I mean, but look, thank you all. Thank you very much, Andrew. Thank you to everybody who came today, and especially those of you who shared some of your own experiences, lived experience and living experience within the chat, which is always really important in order to ground the work that we're doing. So yeah, just a reminder, please join us on LinkedIn, follow us on LinkedIn, sign up to the email list. I saw somebody ask a question there about how soon we might get this video recording so you can share it with colleagues. And as Carla said, hopefully by the end of the week. So then you can keep that conversation going. But please follow along. We'll have another of these webinars again. Thank you all very much for joining us. Thanks, Elizabeth, Sean and Carla. Special thanks, Andrew, for your work and your contributions. And yeah, thanks everyone, and we'll see you all next time. Cheers.